live on YouTube. Today is a pretty lecture heavy day. We haven't had one in quite a while that was so lecture heavy. So I'm going to do my best to get through this. I would like to save time for our discussion, next discussion. So, but still, please let me know if you have questions, but just know that I am going to sort of charge through this. But today's lecture is going to be divided into two parts. The first part is on basically steroid use, performance enhancing drugs, and then the second part is primarily on depression and bipolar depression uh, in women as it relates to cycling hormones. So the history of performance enhancing drugs has been around for quite some time, really since, I think one could argue that performance enhancing drugs were used probably before people kept written records. But when the Greeks decided to write this down, they wrote that they used certain mushrooms and plant seed to increase performance. Romans also used drugs to increase performance of horses and gladiators to increase crowd response. In fact, to this day, in horse racing countries, performance enhancing use in horses might be even a greater problem than it is in the Olympics for humans. In 1849, you know of Berthold's famous experiment with the testes, and then you also remember Charles Brown Sequard's testicular extract studies and sort of sideshow. Steroids, as we know them today, were really first developed in the 1930s. They were used by Germans on their soldiers and in animals during World War II, in addition to other things to make up for a lack of nutrition. In the 1950s, they were first used for athletic purposes in Russia and Europe, primarily for weightlifting. By the mid 1950s, it was discovered that testosterone was a driving force behind increased athletic performance. It has been used in all levels of sport. In the 1972 Olympics, approximately 68% of athletes reported using anabolic steroids. In 1991, the Federal Anabolic Control Act classified steroids as a Schedule III drug, and as you know, the controversy continues today. In recent statistical surveys, 3.6% of high school students in the US admitted to abusing steroids. This has risen nearly 2% in the 2000s. Only drug other than ecstasy that's shown an increase. Interestingly, most adolescents are using, you guys are using less drugs than your parents. Good job. Men that abuse steroids have a high incidence of some form of opioid abuse. In fact, you're going to see that as a sort of a common theme. There's a lot of poly drug abuse out there that is probably associated with a lot of the negative outcomes associated with steroids. Over 3 million people in the US have reported the use of steroids, and approximately 15% of NCAA athletes use them. This chart is just to give you an example of some of the motivation for using anabolic steroids, and also think about it in relation to protein intake. First you can see across at the very top, steroids are not going to be effective if you are not substantially increasing your protein, or essentially the building blocks of the muscles. But it is also worth noting that you can take a whole bunch of protein and you're only going to see a negligible benefit relative to what would occur if you were also to use steroids with the protein. The steroids essentially influence your RNA to help build muscle out of protein. Testosterone is produced by Leydig cells in the testes. This is responsible for secondary sex characteristics in men. Sex glands, libido, reduced body fat percentage, increased body hair are all a result of elevated testosterone levels.
I have a quick question.
Yes.
So this is related to steroids in general. I know somebody from my previous college before I transferred who used pituitary growth hormone, and I have no idea why they would use that. What would be some of the reasons for somebody using that? Because apparently it's like $150 for a bottle, which is kind of ridiculous.
Yeah, there are lots of reasons that people use growth hormone. It has a cult-like following. You'll actually find male anti-aging clinics out there, even in Denver, that where they actually have doctors prescribing this stuff for a considerable profit. And some people think that it basically staves off old age. So with the idea that testosterone and growth hormone decrease, as you age, increasing them might prevent, but it is also thought to, help you, grow leaner. I don't know that it's as effective at helping you build muscles as testosterone or a DMT would do to an athlete. However, it has had a cult-like following. You might recall Peyton Manning. Peyton Manning, got into some controversy where his wife, for whatever reason, was receiving prescriptions of growth hormone. Uh, so, I think that, growth hormone is also commonly used, and whether you would see it used in conjunction with steroids in like pyramids or stacks is something that I think you would find very likely. I would also be willing to bet that, I believe that the cycling scandal, the US cycling team, mixed a lot of testosterone based or steroids that resemble testosterone with growth hormone supplements. Anybody else out there, have any additional knowledge on growth hormones and why people abuse them?
I've known a couple of guys in the like special operations community who take them. It's pretty prevalent actually in the special operations community because one, they're asking so much of their body, the Army or the Navy or, whichever branch is asking so much of their body to prepare for war in the most extreme situations where you have to be at peak physical condition. So, I think, of course, there's a lot of layers psychologically and fitting in that tribe, one, and not failing, two, being so adverse to failure and things like that. But that aside, I kind of just wanted to ask a side question real quick, and then if we can come back to it later. But there were several of us that were talking in the chat. We were thinking we were going to do something, a PowerPoint lecture about not psychological, circadian rhythms, since that was what Reading Check 9 was about.
Yeah, that
Sorry to detract off the question.
Yeah, no, that is a great question. I was sent this PowerPoint presentation. It's possible that I have the wrong one, which would be unfortunate. I can talk to you about circadian rhythms. I don't even need a PowerPoint presentation for it. Would you guys rather hear about circadian rhythms?
I just want to hear about the information that's on the quiz 5 for Sunday, to be honest.
Fair enough.
That's my biggest concern.
Yeah. So what I'm going to do is I'm going to push ahead here with this PowerPoint presentation. If this is not what quiz 5 is on, which I'm going to have to check, I will either, what I would do in that case is just basically eliminate that quiz. That work for everybody?
Yeah, thanks for addressing that. Appreciate it.
Yeah, sorry, that's odd. But, anyway, this is also important, but I do love circadian rhythms. And that is something that I have actually studied a little bit myself, in terms of drug addiction. And, frankly, know a lot more about that than I do estrogen. But anyway, and then, I've also heard that growth hormone can help in recovery, then again, a lot of things are said about these things, but it might speed recovery as well. But anyway, and I've also heard that there are a lot of special op forces that use growth hormone amongst other steroids possibly. But testosterone can be converted to estradiol by aromatase, which is an enzyme that removes 19 methyls from the steroid structure and forms 3 double bonds on the A ring. Obviously, you're not going to be required for the organic chemistry. DHT is an incredibly potent testosterone or hormone that is 4 times as potent as testosterone based on the testosterone molecule. Dihydrotestosterone, or DHT, you'll commonly hear in steroid circles, bodybuilding circles. DHT binds to receptors much more avidly than testosterone. 5-alpha reductase is present in high amounts in tissue of the prostate, skin, scalp, liver, and central nervous system. What are steroids? Steroids are fat-soluble molecules which contain a system of 4 rings made up of 17 carbon atoms. These include cholesterol, estrogen, and testosterone. An anabolic steroid specifically is any hormonal substance chemically and pharmacologically related to testosterone that promotes muscle growth. There are 2 main flavors, anabolic and androgenic. Androgenic is more related to sex. Anabolic is more related to building, like building muscle, skeleton, bone density, hemoglobin, etc. There are also anabolic androgenic, the AAS, which is essentially thinking of this as a ratio where chemists that are trying to improve performance, bigger, faster, stronger, are interested in increasing the anabolic property relative to the androgenic property. So testosterone would have a baseline of 1, and those used most commonly in athletes, you would want to see increase the anabolic side of that. So you're not necessarily growing hair in weird places. So here you can see how the index, I don't know that I'd really call it the therapeutic index, but anyway, the index of anabolic to androgenic function here across some common trade names with their generic names as well. Generic names would be what they're most commonly referred to, and trade names would be what they're marketed by a pharmaceutical company. But you can see that these can get up to 15 to 20%, 20 times higher at hitting the anabolic than the androgenic side.
Can I ask a question about that?
Yes.
What is the therapeutic index? Like, is it the higher the number, the better, or the closer to 1, the better?
Yeah, that's why I don't really love the term here. So therapeutic index is technically, technically it takes into account both the ED50 and the LD50 of a drug. And the therapeutic index would be, basically a window in which the drug is safe, where you are away from the lethal dose in 50, and the LD50 means 50% of lethal in 50% of the population. Effective dose would be effective at producing the desired effect in 50% of the population. And, the therapeutic index or window tends to be, in between those numbers, almost trying to completely eliminate the lethal component. And, that is typically how I think of therapeutic index in the terms of pharmacology. Here, it's looking at it a little differently. So rather than therapeutic index there, I would prefer, basically anabolic to androgenic steroid ratio. I think that's what we're going, you're actually seeing there is the AAS ratio rather than like the traditional therapeutic index. Does that help?
Yeah, so in the case of testosterone, you have 1 anabolic effect for every androgenic effect.
Correct.
And then for DECA, you have 11 anabolic effects for every androgenic effect.
Correct. Maximize muscle growth, minimize hair on the back.
Okay.
Good?
Yep, I think so.
Okay. So the historical studies on anabolic steroids suggested that they produce no muscle growth. Can anybody think why that might be? Simply, the people weren't exercising or taking enough protein. If you exercise and take enough protein, anabolic steroids are incredibly effective at helping you grow muscle. They can be administered in a lot of different ways. They're oral preparations. Some people inject them. They come in patches and gels as well. There's also an aerosol form that is especially hard to detect in drug tests, and sublingual preparations where you would, sublingual is basically under the tongue, getting into the capillary bed under the tongue or under the gums. It does help you avoid digestive systems, the digestive system, the liver, the hepatic portal system. When you take something orally, it typically cuts it by about 50%. About half is metabolized before it enters the blood. So therefore, most, regular abusers of whatever end up finding ways around the hepatic portal system, even though they're quite dangerous at times, to get the drug into the blood at a higher concentration. Common terms that you see when you are, or hear when you are around users of steroids are cycle, stacking, and pyramiding. A cycle would be a period of time ranging from 1 to 4 months in which a steroid user takes steroids. Stacking would be combining 2 or more of these. So here you could also possibly throw in growth hormone, for example. And then pyramiding is also, quite common. The idea is that you don't want to just go cold turkey off one of these. You want to taper off at the end while also avoiding the drug test, I guess, is also a key component here. But if you just crash right off of it, as we'll get to in a minute, the cycling levels of hormones will lead to negative outcomes and depression. Activation of, so why do steroids produce muscle? They activate RNA, resulting in protein synthesis. There's also an anti-catabolic effect that results from blocking the action of cortisol, which would break down energy stores in muscles. It also results in increased free testosterone levels and stimulates activity of insulin-like growth factor. There are multiple clinical applications for which anabolic steroids are approved. One would be bone metabolism conditions. Another would be testosterone deficiency, cardiovascular conditions, and AIDS. Testosterone is oftenly linked to aggression. So let's delve into that a little bit and, consider this skeptically for a bit. Testosterone is commonly associated with social dominance. There are some studies to support that. Testosterone is thought to exacerbate flight or fight responses. There are studies that indicate an increase in aggression in animals treated with steroids. There are also a variety of prison and situational studies in which populations that are tend to aggress have higher testosterone levels. Steroids can act on the limbic system in the brain. They can act on neurotransmitters. In pretty high doses, steroids can alter the function of and increase the number of receptors in a variety of limbic pathways, and can also modulate other neurotransmitters, including dopamine, serotonin, and GABA in the brain. However, it is still a little, there's probably a little more nuance to the whole roid rage phenomenon than you might think. Obviously we've all probably seen a movie where roid rage has been portrayed in some, typically football player, that goes and just starts beating people up. But, I don't know that it's quite clear cut like that. Animal studies have shown that there's an increase in androgen receptors and an increased binding capacity of these receptors after prolonged steroid use, which might support a physiological basis for roid rage. And it's thought that after steroid use is halted, concentrations of dopamine and serotonin are low, which can result in someone acting out or lashing out. Anger often goes up when serotonin plummets as well. So there might be a greater tendency to lash out when one suddenly goes off of steroids. But most evidence, really, if you look at it from the big picture, is somewhat anecdotal or based on case studies. There are very few, if any, prospective random controlled clinical trials that show a very clear risk between steroid use and roid rage. In one, Dark et al. Examined sudden and unnatural death in steroid users and found that, of note, 23 of 24 of the cases often had other drugs on board simultaneously, most commonly psychostimulants. So, one idea out there is that, it's possible that, roid rage is often mislabeled with polydrug abuse. And, maybe if you are, this stereotypical, and I believe this very much is just a stereotype, but, the stereotypical roid rage football player person, maybe you are also, desensitized to violence. Maybe you have been glorified for violence. Maybe you are abusing other drugs. Maybe you feel somewhat invincible from the law and committing acts of violence. So I do think that it's a little more complicated than just assuming that someone taking steroids is going to exhibit roid rage. And then in another study, Lundholm et al. Studied over 10,000 Swedish males and found that men who've used steroids are not more likely to be convicted of violence after accounting for other drug use. Previous research has found correlations between steroid use and violent crime, but that still doesn't establish causation. True cause of the association might be that people who use steroids also tend to use other drugs like amphetamine and cocaine, and this substance abuse might be more strongly linked to violence. Now let's switch gears to talk about women and depression. We are signaling out women for a couple of reasons. One is because depression is more prominent or more prevalent amongst females. And another is that women have very clear hormonal fluctuations and cycles that might be related to some of the symptoms of depression and other mood disorders. So that is really what we're going to explore here during the second half of this lecture. I'm sure that you guys probably know more about depression than I do, quite frankly, but, unipolar depression is, of course, what I'm going to be calling, MDD. But, unipolar depression is most prominent in females, characterized by, basically a sad mood for months at a time. You cannot be you're not depressed if you feel sad for a weekend. Is the cutoff still 3 months or 6 months, or I don't know what the DSM-5 says. But the bipolar disorder is a little different in that there's cycling between manic and depressive states. It can last weeks or months. This also can occur in a rapid cycling fashion. There are also two different types of bipolar disorder that are typically classified based on how pronounced the mania is. Mood symptoms related to there are also very clear mood syndromes related to hormonal shifts, which I think are specifically important for women health or female health. One would be what I'm going to call PMDD, or premenstrual dysphoric disorder. Another is postpartum depression. And then we will also talk a little bit about perimenopausal and postmenopausal depression. So first, depression is very highly prevalent in society. There's evidence that around 21% of women, report, depression, which is much more than in men. PMDD, or is somewhat a controversial subject. It is thought that approximately 5% of women suffer from PMDD. We will go over some of the signs and symptoms of that. And I will also point out that there are pharmaceutical remedies to PMDD, which suggests to me that it might not be a complete myth. But then again, one could argue things about placebo effect and other things. But as a pharmacologist, that is pretty striking evidence from my perspective or my purview. But anyway, there are several postpartum affective illnesses that are also, can be very prevalent. Around 10% of all women that have had given birth, report postpartum depression. Around 26 to 85% report the postpartum blues, which are basically depression-like symptoms up to 10 days after birth. And then in 10% of women, that continues for 4 weeks or more. That is not a trivial thing. And 10% is a pretty high number. I mean, think about that just in this room alone, or this virtual room. There's also postpartum psychosis that can occur in around less than 1% of the population. Perimenopausal depression is also pretty common. There is a 10% incidence of major depression episode symptoms early on into menopause, resulting in a rate that would be about 4 to 1, what you would expect comparing women to men. So what are the differences between postpartum blues, postpartum depression, and postpartum psychosis? Again, we've already gone over the differences in prevalence rates. Postpartum depression, you really pile on a lot of guilt. There's a lot of guilt, anxiety, general depression, and even suicidal ideation and fatigue can occur. Postpartum psychosis, you tend to have mixed or rapid cycling of mood, more agitation, delusions, and hallucinations. This can be especially severe, considered a psychiatric emergency, often necessitating hospitalization. Postpartum depression is relatively moderate to severe, but it can have a very prolonged course that can require medication, amongst other things, which can become complicated, especially when you think about things like breastfeeding, but then again, health should come first.
I have a question about that.
Yes.
Just by definition of psychosis, because it seems like it has a lot of tie into maybe like schizophrenia or schizoaffective disorder, or even bipolar disorder, where you have the disorganized behavior and such, and delusions and hallucinations specifically to schizophrenia. I'm sure there's not a hard line in the sand, but what's the delineation between depression and psychosis? Is it the more disorganized behavior?
Great question. So, schizophrenia is typically divided into negative symptoms, positive symptoms, and cognitive symptoms. The positive symptoms would be, one of the positive symptoms is psychosis. Psychosis is a symptom that is, most best characterized by having basically delusions, hallucinations, these sorts of things that are otherwise not there. Disorganized behavior and cognitive impairment, I would actually classify as something other than psychosis. I would call those cognitive deficits of related to a mental health issue. So psychosis on the nose would be more the delusions and hallucinations. And, now how does that relate to schizoaffective disorder is a very good question. And how does that look different than bipolar disorder? I'm not a clinician, and I think that those two start to look very similar. However, one distinction would just be the delusions and hallucinations, which are really the textbook definition of psychosis. You could be manic and have a very heightened, elevated, basically freaking out about everything, but not really have very clear delusions and hallucinations, which I think is what I would, say you would have to really be, um, have a schizoaffective disorder or psychosis. Does that make sense?
Yeah, that helps me, I think, a little bit delineate the two.
And really, you can even have schizophrenia without showing many symptoms of delusions and hallucinations. It's not completely unheard of. Those symptoms, vary a little bit from subject to subject. But the delusions and hallucinations, definitely, that is what's most on point with psychosis. Postpartum depression, obviously goes up quite a bit after the postpartum period. Like the idea is after birth, you can see within subject differences, substantially increasing the rate of depression occurring in approximately 10% of women, which is an incredibly high amount, really, if you think about it, 1 in 10. Really, we're going to get into this theme here is, so what do we know about hormonal fluctuations and mood changes? There seems to be a sort of common theme here emerging that, the fluctuations seem to be very important. So, I'm going to make an argument here in a few minutes that, estrogen is very important at staving off depression. But if that were true, then why are women more likely to be depressed than men? Of course, we could always fall back to this, reporting issue. However, let's just ignore that for the moment and focus on that it might not be the estrogen itself, but the fluctuations in estrogen and progesterone that seem to be, very influential, possibly, on mood. So, what is happening with PMS and PMDD? There have been numerous studies that have tested whether women with PMS have increased or decreased levels of progesterone or estrogen during the luteal phase. No specific hormonal abnormalities have been identified to account for reproductive endocrine-linked mood disorders. Therefore, there is no reason to use hormonal levels as part of the diagnostic evaluation for PMS on the nose. But I do think that it's still interesting to look at some of the cycling and how that might relate to some levels of self-report. So some women may have a vulnerability to depression that is triggered by exposure to normal cyclical fluctuations of ovarian hormones, as well as sociocultural and psychological variables. It's also possible that, based on, just sheer statistics, if you look at a full sample, you are going to basically normalize out some observations related to hormonal fluctuation and mood. So I've already mentioned that PMDD is incredibly controversial. One question is it real and worth identifying? I don't really have a right answer to that. There are certainly people out there that would say that it is a myth, and there are certain people out there that would say it is like very much a real thing, and should be, considered a reasonable thing to talk to with your doctor and request treatment for it. There are some feminist concerns about the abuse of the diagnosis of PMDD. As I mentioned in the very beginning introductory lecture, it has been successfully used as a defense for homicide. There has been a lack of pretty good research on the subject of PMDD. And there's also been an incredibly unfortunate promotion of ineffective treatments that really is still running rampant. Chances are you've probably seen one of these sort of snake oil type situations. PMDD, if it is a thing, and it does appear to occur in up to 5% of women, may cause, if you really calculate this out, 1,400 to 2,800 symptomatic days across childbearing years, which is equivalent to 3 to 8 years of symptoms. So I don't know. If it were me, I don't know that I'd really want to completely discount something that could affect me for up to 8 years of my life. So what is PMDD? It can be defined as occurring in most menstrual cycles during the past year. 5 or more of the following symptoms would have to be present during the last week of the luteal phase. This would include marked depressed mood, marked anxiety, affective lability, persistent and marked anger or irritability, decreased interest in usual activities, subjective sense of difficulty in concentrating, lethargy, marked change in appetite, hypersomnia or insomnia, a subjective sense of being overwhelmed or out of control, and various physical symptoms. The disturbance would need to markedly interfere with work or school. The disturbance is not merely an exacerbation of the symptoms of another disorder. And criteria A, B, and C must be confirmed by prospective daily ratings during at least 2 consecutive symptomatic cycles. So one thing that as a pharmacologist really interests me about PMDD is that there are many reports that of people that suffer from it or report suffering from it, pharmacotherapy is very effective. What is and possibly even more interesting to me is that SSRIs seem to be very effective at treating PMDD. This has been confirmed using large multi-center placebo-controlled trials. And interestingly, it has been shown to be effective intermittently. So if you happen to take my drugs, brain, and behavior class, and I touch on it in behavioral neuro as well, SSRIs are thought to treat depression by leading to receptor changes over the course of a couple of weeks. SSRIs are not instantly effective in treating depression. So something different is going on here. You cannot take an SSRI and have any effect on unipolar depression. It can take 2 weeks to occur and then still not be effective in a good percentage of the population. However, it still is effective in a good percentage of the population. Here, SSRIs seem to be effective relative to placebo at treating PMDD, which I think gets back to this idea of the fluctuating levels of not only hormones, but also neurochemicals and the interplay between the endocrine and neural systems. I think this might suggest that the SSRI is preventing sort of the sudden drop in serotonin that could be associated with some of the mood symptoms of PMDD.
I have a question about that as well, sorry.
Oh, please.
Do you know of any studies that have compared maybe like SSRI efficacy when estrogen is high compared to when it is low? Because that seems like it could be the determining factor maybe of what, or at least one of the ingredients that would say SSRIs are effective after 2 weeks versus SSRIs are effective after 2 days.
Yeah. I think that's a two-pronged question. the second part, I don't think that that's because of estrogen, that it takes 2 weeks, because the same thing occurs in men. So I do think that, there are sort of like a downregulation of and desensitization of certain receptors associated with serotonin and noradrenaline that seem to be why it takes a couple of weeks to see an SSRI or a tricyclic produce positive effects for some people in depression. Now, the other part is whether or not estrogen levels influence the efficacy of an SSRI. That, I think, is a very good question, one that I do not know the answer to. And, I think that it will be hard to pin down, but I smell smoke. I mean, like that sounds like a very feasible thing to me. It's certainly a good idea. I'm just not familiar of a study off the top of my head looking at those two variables as they would interact. Yeah, it's a very good thought. I can't tell you that. I mean, like
Ask.
both estrogen and SSRIs have been used in postmenopause, and effectiveness varies. So, if that says anything, yeah. Anyway, any other question or a loose end on that one? All right. There's also evidence that gonadotropin releasing hormone agonists can influence PMDD. Essentially, these can induce medical menopause, dramatically reduce PMS symptoms. This is clearly has been clearly effective in several limited clinical trials or case studies. It may be used for severe cases, but of course there are going to be significant side effects of medically inducing menopause. Surgery has also been used effectively. Oophorectomy alleviates symptoms. If hysterectomy is done without the oophorectomy, symptoms will persist. Progesterone is typically not recommended for PMS, even though this has commonly been used and is marketed as essentially a snake oil type situation. I think that my take home on this is that progesterone seems like it can delay the onset of PMS, which I think makes a lot of sense when you think about how the hormones fluctuate over the cycle. So recall that progesterone starts to drop at the end of the luteal phase, so one idea here is that, by increasing progesterone, really what you're going to do is just extend the luteal phase and delay any PMS, not prevent it from happening. It's just sort of like kicking the can down the road a little bit is the way that I see it. What about oral contraceptives? These are widely prescribed, for this reason. They've previously found to be provide inconsistent benefit. Newer oral contraceptives with novel progestins and dosing regimens have been found to be effective. Ethinyl estradiol, or drospirenone, has been found to be effective, and it received actually FDA approval for treating PMDD. There is also an extended cycle combined oral contraceptive known as levonorgestrel that basically creates a 3-month cycle, and this is also under study for the treatment of PMDD. Bipolar disorder, we've already touched on a little bit, but this is unusually intense emotional states that occur in distinct periods called mood episodes, cycling between a manic phase and a depressive phase. Men and women with bipolar disorder have equal prevalence rates and similar age of onset, but the outcomes that you see differ. First, in women, you are more likely to see rapid cycling bipolar disorder, which could possibly be associated with or triggered by hormonal transitions. From some evidence derived from studies of lithium failure, you can see various factors of bipolar disorder, and the prevalence can be as high as 15% for the sort of rapid cycling form. This is not a stable phenotype. It is, very destructive and, well, right. I mean, it is essentially 4 or more episodes within a 12-month period. Some of the most common predictors are being female, using antidepressant use, which could just be, obvious correlation, and thyroid disease, which would also, of course, influence hormonal fluctuation and balance. So essentially, what you can see here is a pretty obvious graph. If you think about it, you can see rapid cycling and non-rapid cycling episodes over a 12-month period. You see more episodes in rapid cycling patients. Interestingly, though, you see a big effect of sex if you look at the reports of the frequency of episodes. If you are only talking about 1 to 3 episodes per year, there's really no difference at all between reports of men and women, but of those that are reporting 9 to 24 rapid cycles per year, you will see that that is almost exclusively in females. Right, I already went over that. Okay, so one idea here is that the increased depressive episodes in women with bipolar disorder can lead to increased antidepressant use. Another is that hormonal fluctuations act to drive episodic frequency. Unipolar syndromes occur during drops in estrogen and progesterone, as would occur during the premenstrual period, postpartum depression, and perimenopause. Iatrogenic affective symptoms are those that result from hormonal replacement therapy. These can basically will influence depression scores. In addition, affective symptoms can change with oral contraceptive pills in some cases and following gonadotropin releasing hormone agonists. So, this goes back to a little bit like, what do we know about bipolar disorder during times of hormonal flux? This has been speculated on for over 100 years. Early on, Kraepelin, estimated that around 7% of women in asylums had been symptoms originating in the postpartum period. Found on psychosis, catatonia, and delirium. Specifically, he said where mania really appears in the pubertal state, it is only a link in the chain of attacks of maniacal depressive insanity. The puberrium cannot therefore be regarded as the cause, but only as the last impulse to the outbreak of the disease. So, hormonal fluctuations and people acting a little, different. There have been a couple studies that have clearly demonstrated relationships between bipolar disorder and fluctuations in hormones. In one half of bipolar women reported severe emotional disturbance related to childbirth, 1/3 of these began actually during the pregnancy. And then in another retrospective study of women with bipolar disorder, there were high reports of, this increases in following discontinuation of lithium, which would also lead to increased symptoms, but a relationship nonetheless. And here are the results from that latter study. So here you can see weeks 1 through 40 between pregnant and non-pregnant women after discontinuing lithium. As you can see, the proportion that remains stable, is pretty equal. Approximately 50% were able to remain stable after 40 weeks following lithium discontinuation. Here, you're essentially seeing the graph reset, which I don't really love the way that they diagram this, but essentially they have the graph reset to 100, which I, again, don't really think is that accurate. But between, you can see in postpartum women, then at that point, you see a significant change of continued deterioration versus those that were not pregnant, suggesting an interaction between postpartum symptoms and the bipolar symptoms. So there's this working hypothesis that rapid cycling is more common in women due to triggering by hormonal cycles. Here, the idea is mood should fluctuate in relation to the menstrual cycle in women with rapid cycling bipolar disorder, and that episodes may preferentially originate in particular phases of the menstrual cycle. This is, somewhat support, some support. Here, I will show you some data from 20 female rapid cycling bipolar subjects. They performed daily self-ratings of mood for mean of 12 menstrual cycles. And in the study in general, they found no systematic relationship between mood and cycle, but 11 of the 25 subjects did have consistent changes. One limitation of this study is how the self-ratings of mood occurred. It could have been a little, not exactly what would be used in a study today, let's just say. First, I want to, trigger your memories here regarding estrogen and progesterone shifts at different phases in the cycle. Essentially, the main line there you see is days from the luteinizing phase peak. And you can see that estrogen peaks right before and progesterone peaks after. Estrogen would dip right after the luteal phase. So you can see early follicular, late follicular, early luteal, and late luteal. So where is estrogen the highest? Late follicular? And when does it drop off? Early luteal. So let's look at how the actual results that they found report to these phases. Here you can see Z-score, which is just how much mood changed relative to a baseline value. And these are relatively small changes, but as you can see, they saw the biggest increase in mood during the late follicular phase. What was highest in the late follicular? Estrogen. And here you can see overall change in depressed mood. Again, it didn't transfer here, but early follicular, late follicular, 3 is early luteal. Remember, in early luteal was estrogen high or low? That's where estrogen really started to drop off. So, while not a very clear, significant effect, you can see a little bit of a trend here in which mood is highest in the phase corresponding with higher estrogen and lowest in the phase with lowest estrogen.
I have a quick question about that.
Yes.
I think there was a few slides back. It said mood was not correlated with something. What
Correct.
was that something? It was
Anything. Yeah, they actually did not find a true relationship between mood and cycle.
and cycle. Okay.
Yeah.
Menstrual cycle.
Correct. Or even, I mean, like, you know, looking at the numbers, you know, scientifically speaking, this is not a very good effect, right? You know, that you would not be able to see any sort of statistical significance between the early follicular and the late follicular phase. You know, that you know, if you do know a statistician that can get a difference between those two, I would like to know them. But, you know, it does seem that they, you know, recorded significance between early luteal and possibly late follicular. Even that, I would say, you know, took quite a bit of, you know, statistical know-how, because having looked at tons of data, I don't know how I could get a statistical significant effect out of these data with a repeated measures ANOVA, which is what should be used in this case, seeing how you're performing repeated measurements.
So then, but weren't we just saying a few slides ago about how rapid cycling bipolar disorder was hypothesized to be connected with the cycle, menstrual cycle?
Absolutely, absolutely. And that's exactly what we are exploring. So, I mean, here are the actual data. Like the data, you can see, I think, a weak trend. The article concluded that there really wasn't much of an effect. And mathematically speaking, you know, it certainly isn't a strong effect, right? But, you know, like, for example, for Z-scores, when I have done electrophysiological recordings in the past, I have to get a Z-score of like 1. Like that's not even on the scale to say that I'm seeing a neural encoding event associated with some stimulus. However, you know, that also doesn't mean that there's nothing here either. There certainly isn't just this clear-cut, amazing effect that is just going to be so clear and replicable from study to study. However, I do think that it is worth noting that in the late follicular, when estrogen is highest, you see the highest mood being reported. So I mean, here in the late follicular, estrogen's highest, and then into the early luteal, estrogen levels drop. And then what happens to mood?
It drops as well. And this would be coinciding with at menses, the
Correct.
drops, correct?
Correct.
Is I think what most women would say that they feel like happens.
Agreed. And you know, so right, just I mean, these are what the actual data look like. I mean, they're weak. You know, it's not an incredibly strong effect, but you know, to say that there's nothing there, I don't think is exactly accurate either.
So do you think that it's a matter of the statistical significance not aligning with the clinical significance? Like you were saying in the studies with your electromagnetic physiology, is that what it was? That said you'd have to get like this perfect score for it to be statistically significant. But how relative is that to what happens in the world? How clinically relative is that?
Fair point. Yeah, no, I mean, like what I do in the lab in a controlled setting would be impossible to do here. You know, going back to like what we talked about, I mean, previously, you know, I mean, there are just so many problems that could result in sort of weaker effects here in this particular study. I mean, like to really, you know, first, you know, how are we diagnosing phase? Is there a physiological marker or self-report or assumptions based off of, you know, when menses occurred? You know, most likely this involved an incredible amount of self-report. You know, So, how could we do this more objectively and actually tie it to hormonal levels that were taken at relevant times? And then how do you measure the hormone at a relevant time? That becomes very problematic and difficult. To really do it well, I think I would love to have, be able to bring in, like I order my rats, I would just bring in a bunch of women, hook them up to machinery all day and walk around with things drop like an IV line and things sticking out of their head. And obviously you cannot do that. So, I do think that there is quite a bit of, as you pointed out, issues associated with, how the clinical ethical constraints of performing a study like this might make it more difficult to derive a perfectly clear correlation versus what I would do with rats in a lab study. Does that hit your question on the head?
Yeah.
Perfect. So, from this, all subjects had at least one dimension of mood, which varied significantly with menstrual phase. There were differences between individuals in phase responses in relationships, suggesting that, there could be subgroups in here. As a group, they did see elevated mood in the late follicular and depressed mood in the early follicular. Yeah, I think that's supposed to say earlier luteal. Because, yeah, it certainly doesn't look that way in the early follicular. If anything, it seems, well, anyway. Right, there are some weak observations, so in summary, I would say that, during this late follicular period where estrogen is going to be the highest, you do see sort of a tendency to elevated mood. And then into the luteal phase where you see fluctuations start to occur, you can see a change in mood. And, there also seem to be some depression associated with the early follicular phase as well. So there is some evidence to suggest that estrogen may serve as sort of a natural antidepressant. There are multiple interactions with the CNS, including effects on neurotransmitters, intracellular and membrane receptors in multiple regions. You see increased available concentration and utilization of serotonin associated with estrogen. And there are polymorphisms in estrogen receptors that seem to be linked to risk of late life depression. Here is just a graph showing the relationship between brain serotonin activity and estrogen. The two seem to rise and fall together. Estrogen has multiple effects on serotonin. It increases tryptophan hydroxylase, which synthesizes serotonin, decreases serotonin transporters, so there's going to be more serotonin in the extrasynaptic space, decreases 5-HT1A autoreceptors, something that antidepressants also do. These reduce the amount of serotonin released per action potential and decrease MAO enzymes, which also break down serotonin. You may have heard of MAO inhibitors, ancient antidepressant. So anyway, we are out of time. I really only have, well, here, I only have one more slide, so let me just power through it. The big picture here is that there are a wide array of factors, including environmental factors and gonadal steroids and endocrine function that interact with the brain to lead to changes in overall serotonin levels and mood. Right. I mean, remember that PMDD can be countered with SSRIs, and these are more effective than tricyclics, suggesting that there could be a drop in serotonin in addition associated to, different phases of the menstrual cycle, and increasing serotonin seems to, overcome that or obviate that issue. So in conclusion, mood disorders are influenced by sex, likely via hormonal state and transitions. This allows to some degree of anticipation. Mood disorders are greatly undertreated. The marriage of improved basic science knowledge of hormonal influences on brain and mood, as well as greater understanding of mood disorder phenomenology, provide hope for more specific and effective treatments. Again, some of these correlation and relationships are somewhat weak. Oh, is it really only 10:36? Oh, my watch is fast by 10 minutes. Anyway, mood disorders and how they relate to cycling hormones does seem to vary, however, the effects aren't perfectly clear cut. The literature is somewhat of a mess. And, you do see correlational relationships that are, somewhat muted, but that could be due to difficulties in measuring, hormones as someone is living their daily life. It is not the easiest thing to do in the real world setting. So I'm going to stop the recording here and essentially open up office hours. I will look into the quiz. If the quiz is not on mood, it will be basically cut. So I will make sure that I get to that today and cut the quiz if necessary.
Do you have an idea of what the next lecture is going to be? Because I'm wondering if are we still like matched up with our schedule?
Good question.
Which I have right here in front of me. I'll take a look at it. Because reading check 9 was over, I think, chapter 10. Yeah, Nelson chapter 10, page 513 to 553.
Gotcha.
So the next one is over Nelson 13, pleasure and hormones.
Yep, sure enough. Today was supposed to be on sleep and hormones. So yeah, basically what I'll do is I will just cancel the quiz for this week. And next week, I will likely do pleasure and hormones rather than sleep and hormones. And we might just skip sleep and hormones, seeing how I think it's covered in, sleep is covered in biological basis of behavior and behavioral neuroscience. So I think that's my plan. In case, would you guys really rather have sleep and hormones rather than pleasure and hormones?
I like pleasure and hormones. I like that idea.
All right.
I think that pleasure and hormones sounds much more interesting, especially since I think we could all use a little happiness right now.
Fair enough. Fair enough. I like that idea. Happy. It makes me
I was a bit bummed. I thought we were going to be talking about steroids all day. I was like, oh, this is going to be good.
right. Yeah. Yeah. And then I guess we got sad and talked about depression.
And then we got sad. Yeah. There's this interesting YouTube channel. It has a ridiculous name. It's kind of funny. It's called More Plates,